So the original CHARM trial was a landmark trial in that it included patients with heart failure regardless of ejection fraction, in other words, throughout the entire ejection fraction spectrum. And it was 3 separate trials: CHARM alternative, in which patients who did not tolerate an ACE inhibitor were treated with candesartan versus placebo; CHARM added, in which candesartan was added to an ACE inhibitor; and then CHARM preserved, in which patients with heart failure with preserved ejection fraction, at that time defined as above 40%, were treated with candesartan or placebo. And the interesting results from those series of trials were that candesartan was effective in heart failure with reduced ejection fraction, 40% and below, both in the added and alternative trials, whereas it was not effective in CHARM preserved, heart failure with preserved ejection fraction. Well, since 2003, there has been a lot of interest in further understanding of heart failure with preserved ejection fraction, and also this new concept of heart failure with mid-range ejection fraction. It's clear that patients with heart failure and an ejection fraction between 40 and 50 do not have a normal ejection fraction, but it's equally clear that there's no evidence-based therapy for this category. And this has recently been recognized in the 2016 ESC heart failure guidelines, that this is a heart failure mid-range ejection fraction category that requires further study. We did 2 different types of analysis. First, we divided the population into 3 categories: reduced ejection fraction below 40, mid-range ejection fraction 40 to 49, and preserved ejection fraction 50 and above. And analyzing those 3 categories, we saw that the heart failure with mid-range ejection fraction category, first of all, resembles reduced ejection fraction. So clinically, patients with ejection fraction 40 to 50 are really much more close to those less than 40 and different from those with 50 and above. And then the second, and obviously the most important findings, are the treatment effect. And we saw that the treatment effect of candesartan versus placebo in the mid-range category, 40 to 49, was the same as in the reduced ejection fraction category, whereas there was no effect in the preserved ejection fraction category. So heart failure with mid-range ejection fraction, in terms of clinical characteristics and response to candesartan, resembles heart failure with reduced ejection fraction. Right, so this is a critical question and a difficult one. So we need to note that this is a post hoc analysis in patients studied more than 10 years ago. But nevertheless, it's very tempting to say that from these randomized data, that candesartan and potentially other ARBs are indeed effective in mid-range ejection fraction. But given the limitations of this post hoc analysis, I think this needs to be verified in prospective trials. And there are a lot of different groups and a lot of different agents that are relevant for this mid-range ejection fraction group. So I think we'll see several trials coming up in the future.